Hey, hello everyone. My name is Austin Kaiser. I'm a flight paramedic and the clinical educator over in California. This presentation that we're going to be looking at today is called In the Womb, which is a look at cardiotacography in the EMS setting. Some of the things we're going to be talking about today, we're going to be looking at the role of fetal heart rate monitoring in the pre-hospital setting. We're going to talk about common terminology, which is probably going to be one of the more important things we look at today. We are going to look at different causes of fetal distress and be able to interpret various different findings in that fetal monitoring process. So what is the purpose of fetal monitoring? And it's really simple. It is a look into the fetal brain so we can very easily detect fetal hypoxia and fetal acidemia. Remember that the fetal brain controls the heart, and if the heart doesn't have an adequate supply of blood or oxygen, we can see that reflected as a change in the fetal heart rate. So really can't stress enough that this fetal monitoring is not a look at the fetal heart necessarily, but rather we're really looking at the fetal brain. So before we can start to interpret these fetal monitoring strips, let's go ahead and take a look at the paper. We commonly refer to it as the strip, and it has definitely different measurements on it than a normal EKG would. So looking at the top portion of it, which is the fetal heart rate monitor portion of it, we can see that going from the bottom to the top, we start off at 30 beats per minute, and it tops out at 240 beats per minute. So the measurement, the vertical measurement for every small box, for every soft line is going to be 10 beats per minute. And for every horizontal measurement going from left to right, each small box is going to be 10 seconds. So horizontal measurement from side to side, if you're going from dark line to dark line, or that solid line to solid line, then that's going to be 60 seconds. And now looking at the bottom of the paper, the tachometer section of it, we can see that the tachometer goes from 0 up to 100 millimeters of mercury of force, of pressure, that is exhibited on the tachometer probe. And so if you're going from left to right, you still have that same exact measurement, so 10 seconds for every light line, and from solid line to solid line is 1 minute. And then if we go vertically, every small box is 5 millimeters of mercury of force. Looking at a closer look, just super important to remember that solid line to solid line is 1 minute. All right, so now let's get into some terminology. So pretty important to use uniform terminology, not only when you're doing your reporting, but also when you are doing your documentation. So that way everybody's using the same language. So a couple terms to go over. The first are going to be periodic and episodic. So what do those two mean? Periodic means that whatever the event is, be it an acceleration or a deceleration, that it is occurring with a contraction. So periodic means it occurs with a contraction. Episodic, on the other hand, means that it occurs without a contraction. Peak and nadir should not probably be new terms to many of you. Peak just means the tallest point of some sort of event, and the nadir means the lowest point of some sort of event. So that top red arrow is looking at the nadir of the deceleration, and the bottom red arrow is looking at the peak of that contraction. So this would be a periodic event, right? Because it's occurring with the contraction. As far as multiples go, if you do have more than one fetus in there that you're monitoring, we can see on this EFM strip that there are two separate fetal heart tracings. So we would refer to them as twin A, twin B, or triplet A, triplet B, triplet C, so on and so forth. So just uniformity among those terms. The last common terminology that we're going to look at is the difference between recurrent and intermittent events. So with a recurrent event, it means that there's some sort of event in the fetal heart rate section that is occurring with greater than 50% of the contraction. So recurrent equals whatever the event is, it's occurring with greater than 50% of the contractions, whereas intermittent is any type of event that happens less than 50% of the time when there's a contraction. So less than 50% of the time or greater than. All right, when we're reporting our findings on the fetal monitor, when we're doing a fetal uterine assessment, when we're doing those turnover reports, we use this BADVC reporting flow. We can remember it as babies are definitely very cute, and what that means is baseline, accelerations, decelerations, variability, and then contractions or the uterine assessment. So an example of that would be here on your screen. As you're doing your turnover report, you can say, hey, this is a 35 and 6/7 weeker presenting with a baseline of 145 beats per minute, having intermittent accelerations, no decelerations, and having moderate variability. The mother's having contractions every 5 to 6 minutes, and they last approximately 45 seconds. And so you can see that that's a really nice, easy reporting flow, and you're going to be getting a ton of information in a very short period of time. Another important aspect of reporting is letting the receiving facility know if mother can feel movement, right? So we know that when a child or when a fetus starts to become acidemic, they stop moving. And so if mom can feel baby moving, then we know that the fetus is typically not going to be very acidotic. So going to that first aspect of reporting, going to the baseline. So what is the definition of baseline? It's the average heart rate that is taken over the last 10 minutes. Normal findings would be a heart rate somewhere between 110 to 160 beats per minute. And remember that when we are recording baseline on a fetal monitor, we do not report the snapshot heart rate that we see at the moment we are taking that vital sign. We need to report it in increments of 5 beats per minute. So we would not say that this baby or the fetus has a heart rate of 122 beats per minute off of the fetal monitor. We're going to say that baby has a baseline of 125. So we report it in increments of 5. Remember that there has to be at least 2 minutes of tracing within a 10-minute window in order to find a definitive baseline. And know that baseline excludes any periods of marked variability. So if you're seeing huge swings from 90 beats per minute up to 160 beats per minute because of either a poor tracing or a lot of artifact, or maybe just an incredible amount of marked variability due to the EFM picking up baby and mom periodically, then any periods of marked variability like that are going to be excluded from your findings. So right here on the top two, or on this top one, we can see a pretty consistent baseline other than those little accelerations that we're seeing. And so what would you say that baseline is? I would say that it's probably about 135 beats per minute. So baseline is 135. If we're looking at the bottom one right here, we can see that we also have a pretty consistent baseline outside of those decelerations. So we're going to go ahead and say that baseline is about 140 beats per minute. Tachycardia in the baseline is just defined as anything above 160 beats per minute for greater than 10 minutes. And the etiology of tachycardia is pretty far reaching. So you can have anything from fetal hypoxia to maternal fever, maternal drugs, especially like methamphetamine and cocaine. We can have amnionitis that will cause fetal tachycardia, as well as fetal anemia. So there's a very large differential when you see that sustained fetal tachycardia. And the significance of seeing fetal tachycardia, typically we're going to see it due to some reversible cause like maternal fever. But if we see fetal tachycardia with those late decelerations, especially if there's minimal variability, like we see in this example right here, then we should really start to think fetal hypoxemia and acidemia. But if we're seeing fetal tachycardia that isn't lasting for very long, there's no decelerations, you have moderate variability. It's typically going to be a pretty reassuring sign. But if we do see that sustained tachycardia, minimal variability, and with late decels, then we should start to think about hypoxemia and acidemia. So what is going to be our intervention for fetal tachycardia? Well, the first things first, we need to reverse any of those reversible causes. So does mom have hypoxia? Is she only satting in the 80s? Does mom have a high fever? We need to reduce the fever with antipyretics or maybe even some cool packs. If mom has some sort of oxygenation issue, we need to place her on high flow O2. And then we also need to assure that there's no issues with her RH factors, that there's no RH isoimmunization going on. On the flip side of that coin, we have fetal bradycardia, which is defined as a fetal heart rate less than 110 beats per minute for more than 10 minutes. The etiology of a fetal bradycardia is also far-reaching, just like with the tachycardia. Fetal bradycardia is obviously a little more concerning to us than tachycardia is. Typically, we'll see it as a very late sign of hypoxemia. Typically, you'll have a lot of deceleration events before you start to have a sustained bradycardia. Mom could be taking beta blockers, like did they just get a bunch of labetalol? Mom could be hypotensive. We definitely want to make sure that if mom is hypotensive, that we're repositioning her, and we are going to be treating that hypotension aggressively with either fluids or pressors. And we could see bradycardia from a prolonged cord clamping or cord compression, like in a prolapse situation where we had a lot of decelerations that turned into maybe a prolonged deceleration that now has turned into a change in the baseline to a fetal bradycardia. So something to be very mindful of. There are varying degrees of fetal bradycardia. So pictured here, we have a mild bradycardia. It's generally pretty reassuring. The heart rate's anywhere from 90 to 110. It still has really good variability, not seeing any decelerations. So typically that's not going to be something that gets me super nervous when seeing this. But if you see moderate to severe bradycardia, as pictured here, where you have a bradycardic child with 80 beats per minute, but still having some moderate variability, and is now decreased down to about 60 beats per minute, is having minimal variability, and especially if they're having like really mild late decels, we may just need to think about expeditious delivery for this child because they are just not doing well. So interventions for bradycardia, we're going to treat any type of underlying cause, be it maternal hypoxia, maternal hypotension, as mom on beta blockers. We may need to treat that hypoxia with high flow O2. We need to make sure that mom just didn't get a bunch of labetalol, and we may need to treat that hypotension with fluids or like a phenylephrine infusion or whatever your specific guidelines say to do as far as pressor of choice in that situation. If you have been treating maternal hypoxia and hypotension and you've been repositioning and nothing seems to be reversing this issue and it cannot be resolved after 30 minutes despite resuscitation, then we do need to start thinking about an expeditious delivery or a cesarean. At the very least, you absolutely need to be making contact with medical control. So we've talked about baseline. So the next thing that we talk about is variability. So variability is just defined as fluctuations in the baseline in a 1-minute cycle. So it's kind of a beat-to-beat variability. Variability is the absolute best measure of cerebral function and central nervous system function in the baby. When we have some sort of acidotic state, when we have some sort of cerebral dysfunction, the first thing that is affected is the variability. We measure it from peak to trough, So you can see on this picture right here, the peak in this 1 minute span of time is near the left side of the screen. So the very peak of that heartbeat is near up about 165 beats per minute. And then the trough is right around 150 beats per minute. So we have a 15 beat per minute range going from 150 all the way up to 165. There's 4 classes of variability. You can have absent variability, which would look like an asystole line. You can have minimal variability, which is less than 5 beat per minute fluctuations, meaning less than a half a little box. You can have moderate variability, which is anything from a half a box up to 25 beats per minute, which is 2.5 boxes. And then you can have marked variability, which is greater than 25 beat per minute fluctuations within a 1 minute span of time. We can see on this pretty good examples of what they look like. So up top, that absent variability looks like an asystole line. Minimal variability, we have less than a half a box, a half a little box, beat-to-beat variability within 1 minute. Moderate variability, you have anywhere from 0.5 to 2.5 little boxes within a 60-second span of time. And then marked variability is greater than 2.5 boxes. And then we have this sinusoidal pattern. If you're a math dude like me, then you know what a sine curve is, and that's where they got this name for the sinusoidal pattern. But we'll talk about sinusoidal patterns here in just a few minutes. So variability, what is it? It's the normal irregularity of the cardiac rhythm, and it results from impulses from that cerebral cortex. And so, as I said just a few seconds ago, what you're really doing is you're visualizing the balancing act between the sympathetic and the parasympathetic nervous system in that baby, which is why variability is so important, and it gives you a window into the brain. So let's break down variability. We have that moderate variability, which is anywhere from 6 to 25 beats per minute. And what it really means is that the central nervous system seems to be functioning pretty well. Seeing moderate variability is the absolute most reassuring finding on a fetal monitoring strip. So let me say that again. Moderate variability is the most reassuring finding on the fetal monitoring strip. Absent variability, we saw that fluctuations are absent. It means that it appears to be in a asystole line. And then that minimal variability is less than half a small box. The etiology of those two things is pretty far reaching. We can have anything from hypoxemia and acidemia. It can be caused from certain medications like maternal narcotics or barbiturates or anesthetics can cause decreased variability. It can also just be the normal fetal sleep cycle. If you have decreased variability down to minimal variability for 20 to 40 minutes and then it picks back up to moderate, then it was probably just the fetus sleeping during its normal sleep cycle. It can also be caused from congenital abnormalities or cardiac arrhythmias, and we also tend to see minimal variability with extreme prematurity, so less than 24 weeks gestation. So what are our interventions for somebody who is having minimal variability? And if it's transient, we're going to do really nothing. If it's just lasting for a few minutes due to a normal sleep cycle, or if it's due to a CNS depressant from the mom, we're not going to do a whole lot. But if hypoxemia is suspected, then we are going to reposition the mom on either the left side or the right side, or maybe even Trendelenburg, depending on what she needs. If she's already on her left side and we still see minimal variability, we're going to roll her over to her right side. We may need to treat some hypotension with IV fluids, NS or LR. We may need to correct some hypotension with phenylephrine or whatever your pressor of choice would be. We're going to correct any hypoxia with a non-rebreather with high flow O2. And then we're going to eliminate uterine stimulation. And what that means is that if it is warranted, we're going to be stopping any type of like oxytocin drip or anything like that. So eliminate that uterine stimulation. Market variability, we know, is that huge peak to trough swing in that 60-second period of time greater than 25 beats per minute. And the etiology of it can be anything from mild hypoxemia to a lot of fetal stimulation to medications. And the medications is the thing that I would like to focus on too, because we do tend to see pretty marked variability when we're going into these hospitals and doing resuscitations on mom, and we're stopping contractions, and we give things like terbutaline, or if mom is an asthmatic and having shortness of breath, we give them albuterol. And both of those, albuterol and terbutaline, can cause a transient marked variability in the fetus. And then obviously drugs like methamphetamine, cocaine, and nicotine can also cause marked variability in the fetus. Significance of it: in and of itself, marked variability is not a sign of fetal distress. We need to be looking for other non-reassuring signs like decelerations and baseline changes and things like that. There's that sinusoidal pattern that I said that I was going to talk about. And what it is it's a sine wave. It has these undulating baselines, this up and down and up and down and up and down. It has these regular oscillations, and typically the amplitude is not very high, so anywhere from like 5 to 15 beat per minute from peak to trough. You're not going to see any type of accelerations, but the important thing about it is that it's really smooth. So there's no spikes in the peak. The baseline, if you draw a line right through it, would pretty much cut the sinusoidal pattern in half, and that is the important distinction between a sinusoidal and like a pseudo-sinusoidal, which we'll talk about here in a few seconds, is that it has that really regular and smooth oscillations. And what is the significance of it? Typically, if we see a sinusoidal pattern, we are going to have significant fetal hypoxemia. Oftentimes, it's going to be secondary to fetal anemia, which is oftentimes due to Rh isoimmunization. So really important to be able to pick up that sinusoidal pattern. The pseudo-sinusoidal pattern, so remember that we still have that sine wave, but there's a lot less uniformity. There does appear to be some like beat-to-beat variability, and the biggest thing is that if you look at it, it is not smooth and nice. It's got little spikes, and the deceleration, the oscillations are not all uniform. You typically will have like a little flattening out of the bottom or the trough portion of the heart rate. And the etiology of it is anything from narcotics, narcotic administration to the mom. Amnionitis can cause this as well, but also thumb sucking can cause a sinusoidal pattern, or excuse me, a pseudo-sinusoidal pattern. All right, so we've talked about baseline, we've talked about variability, and now let's go ahead and talk about accelerations. So accelerations are defined as a sudden increase in the fetal heart rate above the baseline that return to the baseline within 2 minutes. The criteria for seeing an acceleration actually depends on the gestational age. So if the baby is greater than 32 weeks in gestation, has a much more developed central nervous system, we need to see at least an increase in the baseline, an increase in the heart rate, a sudden increase in the heart rate of 15 beats per minute for at least 15 seconds. If they're less than 32 weeks gestation, they have a less developed central nervous system, and we will accept anything greater than 10 beat per minute increase over 10 seconds. So greater than 32 weeks is 15 and 15, less than 32 weeks is 10 and 10. Right here on the top portion of it, we can see 3 to 4 accelerations, right? We see these, the 3 on the right that are very, very obvious, and then pretty good case to be made about an additional acceleration on the far left side as well. On the bottom EFM reading, we see at least 2, and then there's a case to be made about the one in the middle as well, depending on that gestational age. It lasts about 15 seconds. So, what are the etiology of accelerations? The etiology is that we are going to be super stoked about that, right? So, we have stimulation from the central nervous system, or excuse me, from the sympathetic nervous system. Fetal movement can cause accelerations, and we know that if a fetus is moving, then it's not going to be acidotic. We can see accelerations during like partial cord compression and things like that, but generally it is going to be a reassuring sign of an intact fetal nervous system, and there is typically not going to be any type of hypoxemia or acidemia if accelerations are present. So you see those A cells, you're going to be a happy camper. Decelerations, on the other hand, are not as great. So the definition is a slowing of the fetal heart rate below the baseline that returns to the baseline within 2 minutes. There are four classifications of decelerations. We can have early decels, late decels, variable decels, and prolonged decels. So let's look first at early decelerations. All right, so let's look at these early decels. So the first thing is that it's going to be a slow or a gradual decrease in the fetal heart rate. The onset to the nadir has to be greater than or equal to 30 seconds, so it is going to be a gradual decrease instead of a sudden increase. But the absolute must to identify the early decel is that the nadir of the decel needs to match with the peak of the contraction. If it does not, then it is not an early decel. Oftentimes, they're pretty perfect mirrors of each other, but sometimes the contraction can end and then it'll still take a few extra 15 or 20 seconds for the baseline to fully, or excuse me, for the heart rate to fully recover back to baseline. So the must is that it is a gradual onset and the nadir of the decel mirror or matches with the peak of the contraction. Right here, we can see that we have a baseline of approximately, we'll say 130. We have uh, minor to moderate variability, and then we see these decelerations here. And if you look at the nadir of these decelerations, they match pretty well with the peak of the contractions. So these are early decels. And in this example, you can see that the contractions are over, and the decelerations are still kind of recovering. So it's not a perfect mirror of each other, but the nadir and the peak match, so these are early decelerations. The etiology of early decels is typically going to be pretty significant for head compression of the fetus, especially during the first stage of labor, and more especially after the mother is 5 centimeters dilated or more. So interventions for early decels is typically going to be nothing unless tachysystole is present. So that's what we're picturing right here. On this photo underneath here, that's tachysystole, so that mom is having tons and tons of contractions, and in which case we would be giving terbutaline or potentially doing some maternal positioning in order to alleviate those early decels. Late decelerations, on the other hand, we can see that they look different than those early decels. So it is still going to be a gradual decrease in the fetal heart rate. Typically, the onset to the nadir takes greater than 30 seconds. There's two musts for a late decel, identifying a late decel. First, the onset of the deceleration must occur after the onset of the contraction, and the nadir of the decel must occur after the peak of the contraction. So we can see on this one that the onset of that deceleration occurs during the peak of the contraction, so way after the onset of the contraction, and the nadir of the deceleration occurs after the contraction is essentially completely done. So we can see that that is a late deceleration. On this first picture, on the top picture right here, we can see 3 separate decelerations, and they're recurrent decelerations. They're happening with greater than 50% of the contractions that we can see, and we have an onset of these decelerations occurring almost after the contraction is completely done. And they absolutely do not line up with the onset of the contraction, right? So the onset of the decel is after the onset of the contraction, and so these are going to be late decelerations. On the bottom, you can see the same exact thing. So the etiology of late decelerations is going to be anything from maternal hypoxemia and hypotension to acidemia or placental insufficiency. So obviously a lot worse than those early decelerations. Variable decels are pretty easy to identify. They typically are going to look like a V or a U, and they have a very sudden onset, which is really what makes them have that distinct V or U looking shape to them. The onset to the nadir has to have less than 30 seconds, or has to occur in less than 30 seconds. They do not have to be periodic like early and late decels, right? Early and late decels have to occur with a contraction in order for you to call it early or late, but a variable deceleration can occur with or without a contraction. They do commonly occur with contractions, but they don't have to. Pictured here, we can see 4 variable decels. They have that very rapid deceleration from the onset to the nadir is occurring in less than 30 seconds. And another pretty significant thing that we see with these variable decels that kind of gives them away is that they have these shoulders on them. So a shoulder is an acceleration that happens right before and or right after a variable deceleration. And we remember from talking about accelerations that we can see accelerations when we have a partial cord clampage, so a partial cord compression, which makes sense because we know that the most common etiology for a variable decel is going to be complete cord compression, or at least partial cord compression. That's why they commonly occur during contractions. You'll get that cord kind of pinched up against baby's shoulder or head, and it partially obstructs that cord or completely obstructs that cord. We'll talk about the significance or the physiology of how it occurs in just a sec when we talk about prolonged decelerations. So prolonged decels, we have a decrease in the fetal heart rate of at least 15 beats per minute, and it lasts longer than 2 minutes. It has to return to baseline before the 10-minute mark, because otherwise that just becomes a change in the baseline. And what do they mean? Oftentimes prolonged decels mean badness, essentially. It means maternal hypotension, recurrent cord compression, some sort of cord prolapse that's causing complete cord compression, tachysystole, so having tons and tons and tons of contractions can cause it, placental abruption can cause it, and maternal seizures can cause it. So we see prolonged decels, we definitely need to be doing something. So we're going to be treating the underlying cause. Is it from maternal hypotension? Is it from persistent cord compression or cord prolapse, which that's the most common reason to see prolonged decels? So do we need to reposition mother? Do we need to maybe insert 2 glove fingers into the vaginal opening to try to decompress that cord, lift the head off of that cord? And do we need to think about maybe doing an expeditious delivery if we can't fix the hypotension or the cord compression that is causing this? So let's talk about late decelerations again. So we know how to identify them, but really we need to put them into 2 different categories on kind of how fast our heart rate starts to go when we see these late decels. So there's 2 types. We can have a late deceleration with preservation of the variability, or a late decel with decreased variability. If you have a late decel but you maintain good moderate variability, it's typically going to be due to some mild hypoxemia, and it's generally not going to be something that you should be freaking out about. We're going to do some mild resuscitation, and oftentimes it's going to fix the issue. So if we have a PaO2 in the fetus that's less than 15, it causes this. It causes like an alpha-adrenergic response inside the baby. which gives them this centralized hypertension, and so you end up getting this baroreceptor mediated vagal response, which causes that deceleration. So mild hypoxemia is a very common cause for these late decels while still maintaining moderate variability. And we're just going to do some positioning. We're going to make sure that mom has an adequate oxygen supply, and oftentimes that's going to fix the problem. So as stated just a second ago, if we have that moderate variability and we're still having little intermittent accelerations, the fetus is most likely not in immediate danger. However, if you have late decels with loss of variability, then we are starting to become more and more concerned. So as that severe hypoxemia starts to form, or that severe acidosis starts to form due to that anaerobic metabolism. If we didn't correct that problem a few slides ago with that PO2 being pretty low, eventually that's going to cause suppression of that fetal nervous system. And we know that if we have suppression of the nervous system, we lose our beat-to-beat variability. If we do not correct this problem, seeing late decelerations with minor variability, we eventually are going to start to see some persistent bradycardia. We're going to start to see a shallowing or a loss of those decelerations, because as the baby gets more and more sick and as this bradycardia continues to become more and more persistent, it'll lose even its vagal response, and so we're going to eventually just see this persistent bradycardia with no decels if you don't fix this problem. So we really, really need to make sure that we're not blunting those brain stem reflexes. We need to make sure that we're correcting that maternal hypotension and hypoxia, and we're repositioning. And I know I've said these three things a bunch of times, but the implications or the consequences of not doing that resuscitation with high flow oxygen and repositioning and making sure that they don't have any hypotension is to prevent this from happening, right? These late decels with loss of variability turning into a persistent fetal bradycardia. So positioning, tocolysis, correct hypotension, and correct hypoxia. That means that we're going to be reducing that cord compression. We're going to be fixing any type of orthostatic hypotension that's happening. We're going to put them either on the left or the right or at Trendelenburg. We're going to be giving a MAG and terbutaline, especially give them terbutaline if we have tachysystole. We're going to be giving them IV fluids and potential phenylephrine, and then we're going to be giving them that high flow oxygen via non-rebreather. As with prolonged decelerations or as with persistent bradycardia, if you're having recurrent late decels, especially if you have decreased variability and you can't fix it despite resuscitation, we need to contact medical direction and consider either some sort of expeditious delivery or be able to talk to somebody and figure out something that we're missing in the resuscitation. So let's talk about variable decels for just one sec. So they're mediated by the vagus nerve. We typically see those shoulders, which I talked about just a few minutes ago, which is those accelerations right before we see those big decelerations. And as promised, I will talk to you about the physiology of them. So typically when the cord is partially compressed, we get this big decrease in the venous return within the baby. And so you have this baroreceptor mediated acceleration to try to have an adequate cardiac output. But then when the cord is fully compressed, as the contraction happens, or as the cord is fully compressed due to whatever, all of a sudden they have this big hypertension because they already had that acell, and now we pinch off their exit essentially. So now they've got this big hypertension happening. And so then you have this vagal response that causes a rapid decrease in the fetal heart rate. And then as soon as that cord stops being compressed and blood flow is reintroduced normally into the fetus, then all of that stuff goes away, and you might have a refractory acceleration afterwards. So that is what causes variable decels, which means that the most important thing we can do is position the mother. If they are recurrent and you're seeing you're seeing them with all these contractions, then we may need to consider tocolysis. Make sure that there's no cord prolapse. That's a huge deal. Typically, if there's cord prolapse, you're going to see these recurrent variable decels, which will turn into a prolonged deceleration. We're going to give mom some O2, and then we're going to consider IV fluids, or even maybe an amnion infusion if that's the problem, if they have that issue. Reassuring findings on an EFM. So we've talked about baseline, we've talked about accelerations and decelerations, and we've talked about variability. So the two biggest reassuring findings on an EFM are the presence of accelerations. That ensures that the fetus is typically not going to be acidotic, and moderate variability. It shows you that there's a mature and functioning nervous system. Even if there is like fetal tachycardia or some mild bradycardia or late decelerations, as long as you have moderate variability, that's typically going to be a reassuring sign. In a study, even with late decels, if the variability is moderate, there was a 97% chance that the pH was greater than 7. So that's a pretty big deal to see that moderate variability. So right here we can see that the top one, we are looking at some accelerations, and so that's a really reassuring sign. And the bottom one, even though we have those late decelerations, we are still seeing moderate variability, and we do see a potential, like a refractory acceleration on the very tail end of that fetal monitoring strip. Some non-reassuring findings. If we have anything with decreased variability, so fetal tachycardia, fetal bradycardia, late decelerations with decreased variability, that is a non-reassuring finding, and we need to be doing aggressive resuscitation. Also, a sinusoidal pattern is a non-reassuring sign because we know that that's from that fetal anemia, typically due to Rh isoimmunization. All right, so we have completed our fetal assessment now with doing our baseline, our ACELs, our decels, and our variability. And now we're going to do our uterine assessment. So let's talk about contractions. So they're defined by frequency and duration. So the frequency is how many contractions there are in a 10-minute window, averaged over the last 30 minutes typically. And the duration is going to be the average duration of each contraction. So there are normal and abnormal findings in terms of the frequency. So a normal finding would be you're having less than or equal to 5 contractions in a 10-minute window, averaged over 30 minutes. So you should not be seeing more than 1 contraction every 2 minutes. That is the fastest that you should see. And that tachysystole that I've been talking about over the past few minutes here is having greater than 5 contractions in a 10-minute window. All right, so contractions can be measured, like I said, from beginning to beginning to determine the frequency. So if we're looking at this strip right here, each one of those hard red lines, those thick red lines, is going to be 1 minute. So we can see that from the beginning of one to the beginning of the next, we have anywhere from, they're a little irregular, so we have 1 minute, 2 minutes, 3 minutes. So we have 3 minutes between that contraction. Between the second and the third contraction, we have 1, 2.5 minutes. So the frequency would be 2.5 to 3 minutes, right? So these contractions are 2.5 to 3 minutes apart. And the duration of the contraction is measured from the beginning of the contraction to the end of the contraction. And looking at these, we can fit just about 6 little boxes inside of each one of those contractions. So I would say that they're lasting about 60 seconds. So we're going to say that they are having contractions every 2.5 to 3 minutes, lasting approximately 60 seconds. In order to have a degree of need for resuscitation in the baby, we have this 3-tiered system that categorizes these strips. We have a category 1, a category 2, and a category 3 fetal monitoring strip. Category 1 is pretty easy. It's essentially a normal good strip. So baseline has to be normal. Accelerations can be present, so they're okay to see. You don't have to have them. Decels have to either be early decels or you can't have any, or absent, so no late decels, no variable decels. Variability has to be moderate. So this is your normal baseline, having accelerations, no decelerations with moderate variability. This is strongly predictive of a normal acid-base balance in the fetus with a good, well-developed central nervous system. Category 3, on the other hand, is a lot less nice. So category 3 are your sinusoidal patterns, your sustained bradycardia, your late decels, your recurrent variable decels with decreased variability. Remember that it really doesn't matter what you see on there as long as you're having moderate variability. It's typically a reassuring sign. But if you start to see badness like bradycardia or late decels with decreased variability, that is highly suggestive of some sort of fetal acidemia, and we need to immediately look for and treat any type of reversible causes like hypoxia, hypotension, cord prolapse, and tachysystole. A category 2 strip is everything in between. There's like 50 different combinations of things that you can have that fall into a category 2 strip, and I'm not going to go over every single one of them, but essentially a category 2 strip is not predictive of acidemia, but it definitely requires continued monitoring, and you may need to do some sort of light resuscitation with those category 2 strips. Remember that we're going to report every single strip with both positive and negative findings. So just because some fetus does not have accelerations doesn't mean we're going to leave that part out, right? So we wouldn't say baseline 145, moderate variability, and then talk about contractions. Just because they don't have decels and they don't have acels, we're still going to keep that in there to maintain uniformity when we are doing our reporting. So we would say baseline 145, no acels, no decels, moderate variability, and then we'll do our uterine assessment as well. So you're always going to give positive findings, but you're also going to let them know of your negative findings as far as no acels, no decels. So let's look at the interpretation for this strip. And remember that when we report our baseline, it's in increments of 5. When we report acels, we want to talk about if they are recurrent or intermittent. We want to talk about with decels what kind of classification it is, as well as the frequency of them. With variability, we're going to do our absent, minor, moderate, or marked variability, and then contractions, we're going to do frequency and duration. So with this one right here, I'm looking at let's just talk about baseline first, and I'll let you guys have a few seconds to work through your interpretation. So remember, it's baseline, acels, decels, variability, and contractions. All right, hopefully you guys have had enough time. If not, pause the video real quick because we're going to be transitioning to the answer here. So this strip, we have a baseline of 130. We did not have any accelerations. We did see that one early decel. We don't have enough on there to really tell us if it's going to be recurrent or intermittent. Variability was moderate, and then there's only one contraction in that 10-minute period of time on the strip, but it lasted for approximately 90 seconds. Strip number 2. All right, again, if you have not had enough time to read the strip, then go ahead and pause the video because we're going to transition to the answer. So we had a baseline of 135. We had recurrent accelerations. We had no decelerations, and we had moderate variability. The uterine assessment is that they were having contractions every 3 to 5 minutes that were lasting approximately 90 seconds. All right, and now we have strip number 3. All right, if you haven't had enough time, go ahead and pause the video. We're going to transition to the answer. So we had a baseline of 145, and keep in mind too that baseline is very subjective, right? So if in these three strip evaluations, if I've said 145 and you said 140 or you said 150, that is totally fine, right? It's a subjective thing. It's difficult to see on these strips, so you're not going to get the baseline perfect every single time. And does it matter? No. You're going to be within 10 to 15 beats per minute of everybody else on their guesses. That does not matter. But being able to identify variability, A cells and D cells, that is much more important. So that strip did not have any accelerations. We could make an argument that there was that one refractory acceleration right at the very end of the strip, but I'm going to go ahead and say no. We were having recurrent late decelerations. Variability was minor to moderate. I would say that if we zoomed in and we actually saw the small boxes, there probably was moderate variability, and the contractions were occurring every 2 to 3 minutes, lasting for 45 to 60 seconds. So, as a recap, when we're doing our turnover report, that's how we're going to report this. We're going to say baseline 145, no A cells, having recurrent late decels with moderate variability, mothers having contractions every 2 to 3 minutes that are lasting between 45 to 60 seconds. And don't forget to let them know if the fetus is moving, or rather if the mother feels the fetus moving. All right, everyone. Well, thank you so much for spending the last hour with me on this fetal monitoring course. If you guys have any questions, feel free to reach out to me at akaiser@phiairmedical.com, and we will see you guys out on the flight line.